If not, are the minutes agreed? Thank you. Correspondence. The correspondence has been circulated. Can I take it that that's noted? The election of a Vice Chair, I'm proposing to put that back to this evening, where we can meet in private session using Microsoft Teams, so we can meet remotely from our offices. I would ask that any members who want to participate in that meeting make sure that they're able to use Microsoft Teams and that they have the technical capability to do so. There are Oireachtas IT staff available to help with that. Is that? Once the third session is completed. Is that agreed? Yes. No, it won't be immediately. I mean, we'll give a reasonable break if people want to grab a sandwich or something. But I think rather than take up time now with this matter that we discussed this evening, is that agreed? Thank you. Speaking slots also, I've liaised extensively with members of the committee and with groupings regarding speaking slots. It's proposed to give every single member of the committee 5 minutes to make a statement, ask a question and receive answers within that 5 minutes. Somebody can give their speaking time to somebody else, subject to the proviso that people can speak for a maximum of 10 minutes at a time. I propose to proceed on that basis for today. We can discuss it again this evening, but I don't want to. Everybody will have 5 minutes. Every single member of the committee has 5 minutes, so everybody is equal from the
second session as well.
Yes.
So we've 10 minutes between the two sessions. But
no, you will have 5 minutes to speak in this session, Deputy O'Dowd. And but if somebody wishes to give you their 5 minutes, they can do that. If you wish to give your 5 minutes to somebody else, you can do that, subject to the proviso that nobody speaks for more than 10 minutes at a time. The only point I want to make is I don't have an issue in theory with that, but that because you won't have the witnesses present in the way we initially expected, you may want to spend more time with one witness than 5 minutes will allow. That's the only problem I see. I appreciate that, but at the same time, if the first speakers if the first speakers are taking more than 5 minutes, people who have a slot later won't get reached, and I think that's quite unfair. I think we need to make sure that every member of the committee has an equal opportunity. The point I'm making, Chairman, is that the limitation we have is a 2-hour session. I understand. No, I just want to make my point. I appreciate you understand all this, but I just want to articulate it clearly to you, because I have questions, I know, not necessarily today, which will exceed 5 minutes, because we expected to have the 10 minutes with the witnesses. That's the point I want to make. Okay. Well, look, Deputy O'Dowd, but I'm not objecting today. I appreciate that, and maybe if you have more than 5 minutes today, you might speak to your colleagues, and maybe somebody might give you an additional 5 minutes on the basis. But Chairman, again, I go back to what I don't want to be. I just want to make this point that, as I understood it, your proposal initially was we'd all have 10 minutes. Based on having a double session, which is not possible now. But the difference is that the same witnesses won't be there. That's the problem. It is. I've made the point. It is going, and we'll take it from there. I appreciate that the time limits which are required of us are going to make it very difficult, but we're going to have to be as concise as possible and maybe make as few statements as possible and try to elicit information rather than make statements, if possible, colleagues. Sure. Thanks. So I don't disagree. There's one, Deputy Doherty.
And I was just a minute late when you were, I think, dealing with the issue in private session about, was it the election of the Vice Chair?
No, we're in public session still.
We're in public session?
Yes.
Sorry, was it the postponement of the election of the Vice Chair till the end of the business?
Yes.
Can I ask what you're indulging that is postponed to the start of the meeting next week?
Does anybody oppose that? No, then that is a good idea. Thank you, Deputy Doherty. Lastly, we need to determine, we have the physical capability to take witnesses from Committee Room 1, where we sit here in the chamber together, whereas they would be in Committee Room 1. I am minded, given the risk of people having to go into self-isolation, and having consulted with a number of you this morning, as many as I could, I didn't have a mobile number for one or two of you, to allow the witnesses to sit in Committee Room 1, and we will ask them questions by video link. It minimises any exposure that they have to this. Relatively, it's not a big group, but it's still 19 members of the Dáil plus Secretariat. So that's a relatively large grouping of people to be in the company of consistently for up to a 2-hour period. So if you agree, I think we will take them by video link from Committee Room 1. If you object, we can go into private session and discuss this. Then we have to, thank you, Deputy Leader, we have to go into private session, then I propose to go into
just very quickly, my only point
if you
is...
just wait for 1 second, because I think
sorry.
the cameras have to
Of course.
be turned off.
My only question is, what is our public health advice? Correctly.
for joining us here this morning. Just to recap, witnesses have the possibility of giving evidence from Committee Room 1 if they prefer not to be in the chamber. You have said that you don't have a preference, so I'd like to thank you very much for coming this morning. I wish to advise the witnesses by virtue of Section 17(2)(1 of the Defamation Act 2009, witnesses are protected by absolute privilege in respect of their evidence to this committee. If you are directed by the committee to cease giving evidence in relation to a particular matter and you continue to do so, you are entitled thereafter only to a qualified privilege in respect of your evidence. You are directed that only evidence connected with the subject matter of these proceedings is to be given, and you are asked to respect the parliamentary practice to the effect that, where possible, you should not criticise or make charges against any person or entity by name or in such a way as to make him, her or it identifiable. Members are reminded of the provisions within Standing Order 186 that the committee shall also refrain from inquiring into the merits of a policy or policies of the government or a minister of the government, or the merits of the objectives of such, or the merits of the objectives of such policies. While we expect witnesses to answer questions asked by the committee clearly and with candour, witnesses can and should expect to be treated fairly, and I will do my utmost to ensure, as I'm sure will all committee members, that they are so treated. Witnesses will any concerns that witnesses have with regard to their treatment, I'd ask them to bring them to the committee's attention, and they will be fully considered in accordance with the witness protocol. Mr. Breslin, can we have your opening statement, please, followed by Dr. Holohan's opening statement? And I would remind members that they will have, every member is being afforded 5 minutes. They can be given a further 5 minutes by a colleague who's further down the speaking list, subject to the proviso that members may have a maximum of a 10-minute slot at any time. That is to make statements, ask questions, and most importantly to leave time for receiving answers. Likewise, for our witnesses, I would ask you to limit your opening statements to 5 minutes. We have received your papers in advance, and we thank you very much for taking the time to prepare those and for having sent them in advance. I would now ask Mr. Breslin to give an opening statement.
I presume, do I remain seated?
Sorry, finally I would ask everybody to remain seated throughout. As in, people are free to leave, and I would encourage people to leave and come back to avail of their slot, so that there are as few people as possible in the chamber, because the more contact we have with people, the more risk obviously there is of spreading Covid-19 or indeed any other infectious disease. I would ask that people sit while addressing addressing colleagues or addressing our witnesses and asking questions, and that they speak through the chair. Thank you, Mr. President.
Thank you, Chairman. I'm outside my usual habitat, so Chairman, committee members, thank you for your invitation to meet with you today. I would like to extend my best wishes to the committee and indeed to the new Dáil in its important work. Just over 17 weeks ago, on the 22nd of January, the World Health Organization announced that there was evidence of human-to-human transmission of the novel coronavirus COVID-19 in Wuhan, China. Since then, the Department of Health, the HSE, the wider health sector and colleagues across the civil and public service and community and voluntary sectors have put in place an unprecedented response to an unprecedented emergency. I am deeply proud of the way in which people in my own organisation have risen to the challenge at great personal cost. We must particularly express our deepest gratitude to the staff of our frontline health service who have met this challenge head-on in what has been the most supreme determination. In the period since we first learnt of Covid-19, there have been over 4.7 million cases confirmed worldwide. At least 315,000 people have died. In Ireland, we have 24,200 confirmed cases. They're the figures as of last night. And unfortunately, 1,547 deaths notified, each of them deeply mourned. All crises come in phases. The public health crisis has a particularly prolonged acute phase. We have made definite progress in getting virus levels back down through stringent public health restrictions. But the social and economic costs of COVID have been huge and will be with us for some time. Yesterday saw the first easing of these measures under the roadmap. The bedrock of this progress has been the tremendous commitment on the part of citizens and communities to the behaviours necessary to reduce transmission. The progress is such that we can now collectively take some calculated risks in extending the range of activities it is permitted to undertake. But we need to be aware that we will continue to be in the acute emergency phase of this crisis for some time, with further waves and ever-present danger. This is not a 1, a 2 or even a 3-day storm after which we move to a recovery phase. The acute phase of this crisis will definitely be measured in months and most probably in years rather than days. Our health service has been tested to the limits but not overwhelmed, as the ECDC and many of us feared. None of us have seen anything like this before. The scale of the challenge is unprecedented, but so too has been the response. There has been a focus on moving quickly to utilise all available resources, recognising that our healthcare capacity is challenged even in normal times. For example, we have introduced payments to GPs for telehealth so as to avoid unnecessary visits to surgeries. The HSE has developed 29 community assessment hubs to avoid unnecessary hospitalisations. Private hospital facilities have been secured in preparation for the surge, and they are now helping with non-COVID care that has been displaced from our major public hospitals. The HSE, voluntary hospitals and other health agencies have worked with private nursing homes to support them in preventing or managing infection and continuing to care for older people. The health service has also been engaged in a massive effort to scale up our COVID-19 testing capacity. COVID-19 is a new virus. 4 months ago, there was no test for the virus, much less commercial supply of such tests, and the infrastructure necessary to undertake testing at scale. The HSE has striven each week to increase testing capacity with the opening of 47 testing centres, commissioning 40 additional labs for the testing of COVID-19 and procuring supplies against a backdrop of global shortages, also implementing IT systems to manage referral and automating processes. The plane has been in flight while all this necessary work to improve its efficiency and range has been undertaken. The issues that have been encountered along the way are well documented, but despite these, Ireland is positioned towards the top of the international testing league table. Ireland is 4th highest in the EU in terms of tests completed in population terms. To date, over 280,000 tests have been conducted. There is much more work to do, in particular improving turnaround times, but this week the HSE is on target to have a testing capacity of 15,000 tests per day, with an average turnaround time from swab to result of between 1 and 3 days. The scale-up of contact tracing by the HSE has also taken place. The median turnaround time for giving someone their positive result and commencing contact tracing is just over 1 day. There are outliers and further improvements are planned and will be necessary to continue to improve turnaround and support any increase in contact tracing requirements associated with the greater circulation of people. Congregated settings are, by virtue of their physical nature and the susceptibility of those living there, recognised by the WHO and ECDC as involving higher risk of infection. The deaths we have experienced in our long-term care facilities are the most difficult aspect of our experience with COVID-19 so far. The testing of those who lost loved ones and can't say goodbye in the normal way is truly heartbreaking. The international experience involving similar, or in some cases worse problems than our own, has been highlighted by the WHO and ECDC, who make specific recommendations for this sector in mid to late March. Our commitment to testing and recording all deaths, wherever they occur, means our figures are much more representative and accurate than in many countries. We have also undertaken a comprehensive survey of deaths in long-term residential care to ensure that we are fully and transparently capturing the actual position. Since the outset of this emergency, there has been a high level of alertness to the vulnerability of older people in general and those in long-term care in particular. Important new and international information has emerged.
I'm sorry to interrupt, but I would ask you to conclude so that we have enough time for questions.
Chairman, we must be frank in acknowledging that a crisis is continuing, and our conclusions must be tentative and preliminary. Because the virus is so new, there is much that we don't know. A proven blueprint was not available at the outset on how this public health crisis would be managed. We are paying careful attention to international advice and experience. Decisions are being made in real time. The threat from the virus will be a reality for the foreseeable future, and we must all protect the space for inquiry and learning.
Thank you very much, Mr. President. I'm just going to ask you to conclude. We have your opening statement, and we appreciate that you sent it to us in advance. Thank you. Dr. Holan, I'd ask you also to give an opening statement, but to limit it to 5 minutes if possible.
Chair and members, and I'd like to thank you and your members of the committee for the invitation to appear before you today, and I want to wish you well with the important work you're undertaking on behalf of the Oireachtas. You've indicated that you wish to focus on 3 specific issues today, and I'm happy to offer a full briefing at any stage on the response to the whole pandemic on behalf of the National Public Health Emergency Team, as I believe such an understanding will be critical to you in supporting you in your work. I welcome the opportunity to explain our response. Maintaining open, clear communications with the public has been a central tenet of the health service response to the COVID-19 pandemic, and to this end, among other things, we have held 52 press conferences to date. Since Covid-19 emerged in China in December 2019, it has spread widely and rapidly around the world, as you've heard. And as of today, we've had 4.5 million cases, with 24,200 in Ireland, and sadly 1,547 people having lost their lives. We're acutely conscious of the grief that people have experienced over the past 3 months, and I would like to take this opportunity to express my deepest condolences to all of those who have lost loved ones. We first heard reports of a novel coronavirus infection during the second week in January. Immediately, senior public health people in this country began to confer, to monitor and to collaborate with colleagues internationally. It became clear from an early stage that this would become a significant challenge for the world. It's equally true that the world's experience with this virus is still unfolding, with tragic consequences for many countries, irrespective of levels of preparedness, wealth or development. And while we've had high levels of preparedness arising from our experience with pandemic influenza and other public health challenges, it was quickly clear to us that this virus was very different. The ease of its transmission, its severity, particularly for those who are vulnerable, combined with the fact that there is no natural immunity to this virus, there are no medicines available for its specific treatment, and there are no vaccines, has presented an unprecedented global public health challenge. To that end, on the 30th of January, the WHO declared a public health emergency of international concern. The NEFIT, which has been at the centre of our public health response, held its first meeting on the 27th of January 2020 and has held 31 meetings to date. Its role has been to provide clear advice to the public on how to protect themselves, their families, their communities, and to provide advice to government when it was necessary to do so through the Minister for Health regarding wider societal public health measures. By the middle of March, it became evident that unprecedented action was needed to prevent spread of infection and high rates of hospitalisation and ICU admissions and significant mortality. And our collective actions have suppressed this infection and protected the health of people in this country and have undoubtedly saved lives. The cornerstone of the response in this country has been based on a public health evaluation of risk and public health informed recommendations to government as to what measures can be taken at each point to minimise the impact of this disease. But there is no certainty that we can keep this virus suppressed. The advice of NEFIT is that we ease restrictions now in a phased-based manner while maintaining close vigilance of the spread and impact of this virus to ensure that we can safely recommence work, social engagement, education and the day-to-day operation of the health service. The NEFIT will continue to advise government through the Minister for Health to ensure that the decisions government takes are informed by public health considerations while recognising that the government will also need to take into account wider economic, social and other considerations as part of the phased unwinding of restrictions. Thank you, Chairman.
And thank you also for being so concise, Dr. Holan. I'd like to call on the first speaker who's going to speak for 10 minutes, having been given an extra 5, Deputy Donnelly.
Thanks, Chair. Mr. Breslin, Dr. Houlihan, welcome to the Chamber. I want to start by thanking you both for the work you've been doing. I know you've been working flat out now for several months. It's greatly appreciated, and I'd like to wish you the very best with your ongoing efforts. Obviously, as you say, Mr. Breslin, we're still very much in the emergency or acute phase of this. We've got 10 minutes, so what I might do is I have 5 questions. I might ask you both the 5 questions, which should give you time to answer, and then if there's time, we can go back and forth. I'll start with testing and tracing. The HSE briefing from last week to the health spokespeople said that the median turnaround time from referral to getting a result back was 5 days. And we heard in the chamber here last week, I believe from the Minister, that the target time is 3 days. It still feels quite long, and I note, Mr. Breslin, you said actually you're now in some instances getting it down to 1 to 3 days. Could I ask what the current position is and what the target is? Is it that we want to get a 24-hour turnaround across the board, or for high-risk groups like healthcare workers, elderly people and so forth? The second question I have is on the impact of the health system. The health system, obviously, before the COVID virus arrived, was struggling. The COVID virus has been catastrophic for healthcare facilities at the moment and ongoing work. But just as worryingly is the medium-term impact. So, Mr. Breslin, you said we could be dealing with this for months and potentially years. My understanding is that where HSE hospitals used to have an occupancy rate, a bed occupancy rate of 95%, that in the COVID world, it'll have to be no more than 80%, so we can guard against a surge. Doctors have said to me that the number of patients that can be operated on in a given theatre list is down by about half because of all of the COVID hygiene and cleaning required. Other consultants have said, and I believe it was discussed here last week, that outpatient clinics, the number of patients that can now be seen by a given doctor and their team in a given session could be down by 30 to 50%. So on top of that, we had Paul Reid say he believed probably an additional €1 billion would be required for PPE on an ongoing basis. So can I ask, has the analysis been done on just how diminished the HSE's healthcare capacity is going to be, how long it is believed that is going to be the case, and what can be done about this extremely challenging situation? That's the second question. The third question is to do with the private hospitals. I think the reason for taking them over made a lot of sense. I think it was a brave thing to do, and we all saw the awful scenes from Italy and other places where patients who were critically ill were being treated in car parks. The situation clearly isn't working at the moment. There seems to be a 30% occupancy rate. The figures that the doctors are collecting suggest that actually it's fallen from last week, that a lot of the operating theatres are not working as much as they could, the diagnostics machines aren't working as they could. About half the consultants have signed up. And it seems at the same time we'll be using public healthcare money to treat private patients in private hospitals, money that would usually be provided by the insurance companies. I think the intention is noble on all sides, that we're trying to procure more healthcare capacity for public patients at this time, but it's clearly not working in terms of using the healthcare assets we have, nor indeed in terms of public money. The NTPF, we're told, has identified about 5,000 public patients who could be treated in private hospitals, whereas with €50 million in the pre-COVID world in 2018, I think they procured about 21,000 procedures. Can I ask at this point, I know there's a review going on, but given that we're spending 115 million or more per month, and given that the assets clearly are not being used, and there are men, women and children around the country now who are suffering, who are deteriorating, in some cases may lose their lives or have permanent damage because of the lack of this capacity being used, is it now time to make a quicker decision to cancel the contract, to retain an option for surge capacity in the future, and to redeploy that money to the NTPF, so that insurance companies would continue to pay for private patients' treatment in private hospitals, and we could supercharge the NTPF and make serious inroads into the public patient waiting lists?
You've almost used up 5 minutes. If you're going to get 2 answers to each of those questions from people, it's a matter for yourself.
Fine, I'll ask one more quick question then, although the answer might be a bit long, which is what the medium to longer term strategy is. So some people are saying we need to crush the curve, as they did in Australia and New Zealand, which allowed them to open up in a wider manner. South Korea has a different approach, which is very comprehensive: test, trace, isolate. Sweden took a different approach, which was broadly to stay open, has about the same fatality rate as us. Is there a strategy, or where is the thinking in terms of how we're going to deal with this, to your point, Mr. Breslin, over months and possibly years? Thank you, Chair.
You wish both witnesses to answer each question?
Yeah, sure. Well, whichever way the witnesses want to do it.
Okay, thank you.
On the testing, you referenced last week at 5 days, and the target, and I think we will achieve it, is to get it down to 3 days for 70% of all tests. There will be further improvement in that. One of the ways of doing that is texting back the negative results, and that will really automate and speed things up. But we do want to continue to improve those, and what we have is a system which was patched together but now needs to be redesigned end to end, and the HSE is doing that, working on its information systems and processing systems to get that down as real time as possible. In relation to the impact on the health service, I would say that on the 5th of May, NEFIT advised that we could restart non-essential care within the health services, and so we are in the process of ramping that up and planning for how we do that in what will be a very different environment. It will undoubtedly take longer to do many procedures. If you take endoscopy, doing a single endoscopy is usually a very quick thing to do. Now you will be putting PPE on, doing the procedure, taking it off again, then decontaminating the area and bringing someone back in. So it will take longer, it will cost more, and there is a good chance we will end up doing less over this period. The way to try and buffer that is through the innovation that we've introduced around use of technology, telehealth and so on, but we will be in a very challenged healthcare environment for the foreseeable future. In relation to private hospitals, I think it is relevant that non-essential care was not taking place in either public or private hospitals up to the start of this month. So we are also in a ramp-up phase in the private hospitals. I think a good deal more than half of the consultants have signed up. We've made good progress in recent days. But you are right, we need to stand back before the end of this month and review that in its entirety. One of the mandates that we got in conducting the negotiations was that we wouldn't have a situation where, during the course of a pandemic, somebody could say that patient is in that private hospital because they have private health insurance and being paid for by the taxpayer. The solidarity would have been undercut in our national effort, and that was the motivation behind the way we have put the arrangement in place. It is important to acknowledge that a further wave or surge could happen at any stage, and we would need that capacity. We're not a health system that is well endowed with capacity. I might come back to the medium longer term strategy because I think it definitely will eat into the remainder of the time for Tony.
Thank you. Dr. Holden.
Just in the interest of time, I won't supplement those answers too much other than to say in relation to the testing and tracing, to not see it in isolation, to see it as part of a set of public health advice, that the public themselves, individuals who experience symptoms, can help in terms of shortening the time to diagnosis by coming earlier. And so our message, in addition to the enhancements that have been made in relation to testing and tracing, is to encourage individuals who are experiencing cold and flu-like symptoms to not put off the phone call to the doctor until tomorrow to see how they are, but to make early contact. That gives us a greater chance, in addition to the improvements that are happening that Mr. Breslin has outlined. In terms of the overall strategy, I could speak at some length about this. I'm conscious of your time. Comparisons have been made to a number of different countries. First of all, I'll say in relation to New Zealand, Western Europe has been the epicentre of this infection. New Zealand is on the other side of the world. It's 2,500 miles from the nearest landmass. It's not part of a political, economic, legal, social, cultural union with a number of other countries like Ireland is. So direct comparisons, I'm not suggesting that you're making them, but others have made, are not entirely valid. The spread of infection to that part of the world was a much, much later event and much, much smaller. And they did take decisive action, as I believe we did in this country. But we were very close to the epicentre of this infection. In a way that New Zealand simply are not. In relation to Sweden, a lot has been said in terms of mortality, and I don't want to point unduly at comparisons between different countries, but we have to be sure that we're counting the same things. We think in terms of direct comparisons, admissions to intensive care are probably more reliable measure of the burden of infection, and Sweden has had a much bigger challenge than this country in relation to that particular measure. They have currently, when I checked yesterday, almost 400 people in intensive care, and if we adjusted that for population, that would be the equivalent of almost 200 people in intensive care right now. We have 50.
Thank you very much, and thank you for staying within the time allocated. Deputy O'Reilly of Sinn Féin.
Thanks,
you
Chair.
have 10 minutes.
And thank you both for your evidence, and thanks for being here. We know how busy you are, and thank you for giving us your time. I propose to do the same as was done previously. I'll ask my questions. If we've time for an interaction, then that's fine. So yesterday, we began the reopening of the economy. I'm conscious that 100,000 construction workers are going back to work. And that is going to pose a challenge. I think it's going to pose a challenge for them in their workplace, for their families when they go home, but also a broader public health challenge. So we're aware that there are specific guidances in place and guidelines for the operation of construction sites. Now, look, we'll have a conversation with people later about how they're going to be enforced. But is there a specific plan to test and trace those people who are now going back to work? Because testing, tracing is much easier, as I'm sure you'll agree, when the country is on pause or shut down. And now as the economy begins to reopen, is there a specific plan in place that will cater for the numbers of people who are now going to be moving around who previously hadn't been doing that? So we note also that there is a specific plan in place for construction workers. Is there similar guidance and advice for transport workers, for postal workers, for other people who are now going to be going to work and have more work to do? Transport workers are going to be bringing people in and out to work. And it has struck me that some of, and maybe it's necessarily so, but some of the measures have been reactive rather than proactive. And in this time, I would have thought that you would have used the time on pause to make preparations for reopening the economy, and perhaps you might outline for us what those are specifically in line with protecting the health, safety and welfare of those workers who will be returning to work out of necessity in the coming days, and indeed some were back at work yesterday. With regard to healthcare workers, the latest figure that I had heard was an infection rate of around 30%, 25 to 30% among our healthcare workers. And I think that's very concerning. I'm sure you're very concerned about that too. Could you comment on that, on how you think that it happened? Because that is not in line. And, you can make comparisons. And I've heard members of the government and others make comparisons between us and Korea and other countries and all of that. You can make all the comparisons that you like, but there's nowhere, that, as far as I'm aware, where that figure is as high as it is. So perhaps you could comment on how it got so high among our healthcare workers and what specific measures are in place. Is it due to the fact that we had chronic understaffing as we came into this? Is that a factor? Maybe you could comment on that. I'm not going to go over the reported tensions that exist between the department and the HSE. All of those have been well ventilated in the public domain. But I do want to refer to reports that there were, following the letter that was published, that there was going to be twice weekly phone calls between the CMO, the head of the HSE and the Secretary General. So I want to ask if those phone calls are happening, if you're finding them useful, if they're minuted, and if the minutes of those can be published so we can all be up to date and up to speed on it. I have a question also with regard to nursing homes. So according to the Minister for Health, on the 19th of February, Paul Reid met with the Director of Nursing Homes Ireland. I'm just wondering what actions were taken, because it does strike me that some time was lost and that the measures put in place in the nursing home sector were, as I have previously described, reactive rather than proactive. But it would seem to me that the opportunity existed there on the 19th of February. So I'm just wondering if you are aware of that meeting, if you were briefed, and what specific actions were taken as a direct result of that. I leave my questions there, and if we have time, we might have more. Thank you.
Thank you, Deputy President. I might take a couple, and I'll ask Tony to come in as well. On the question of NEFIT and the interaction with the HSE, what was put in place after that request from the HSE, we had a teleconference with the HSE chair, myself, the Minister, the CMO and the CEO of the HSE, and what we've agreed is to have a regular weekly teleconference, and that is minuted, where we go through all of the issues as a collective, and it's been very beneficial over the period. Needless to say, the interactions are not just daily, they're almost hourly in between that, but as a centrepiece where everybody comes together, it's proven. They haven't been published yet, but they are publishable. Yeah. In relation to the nursing homes, you asked me about the meeting with the HSE CEO. My understanding of that, but the CEO will be here later, was that people touch base on the kind of preparations the HSE was putting in place and the Nursing Homes Ireland on their preparations, and they agreed to keep in touch and provide support to each other over the period. I can talk in more length about nursing homes in general, but in relation to the specific question, that's the position. I might ask Tony to comment more.
Just in relation to your first question in relation to workers, we've done a lot of work with other government departments and including the Health and Safety Authority, I believe maybe with you in the afternoon, to give you an update in relation to that work, to ensure that our public health advice, if you like, is incorporated into the work that they do in support of and oversight of work and workplaces. In relation to testing specifically, any decision in relation to testing and its role in a particular occupational setting will be taken on a public health assessment at a point in time, if that's something that's valuable and worth doing. But it won't necessarily be the case that particular occupational groups will be subject to, if you like, a sweep of testing unless there's a public health rationale. That might arise. It might arise at a point in time. That will be an assessment on an ongoing basis that's made in relation to the path and the course of the disease. In terms of healthcare workers, we have had a challenge. We've been honest and open about that. The figure is slightly over 30%, just to give you the up-to-date. It's 31.5 I think 5 as of yesterday. It is a high percentage. You have to bear in mind that we have prioritised healthcare workers for testing, and we have completed, unlike many countries, a significant testing programme in residential care facilities, and so the staff in those settings were both tested and then identified as positives, and will all be part of that number. So we think we've been proactive in relation to it, but it has been a challenge, there's no question about that, and it reflects the fact that healthcare workers are in the front line. They are at risk of picking up this infection by virtue of the work that they do. And then there's also the challenge that healthcare workers, when they are infected, are a source of potential infection both for the people that they serve and then for the communities in which they live and are part of. And so that's a particular challenge and continuing concern from our point of view to address that. There has been a substantial fall in the rate of infection among healthcare workers, and so while the number is high, the incidence has been dropping significantly in the last number of weeks.
Working for private companies working in the healthcare sector, so specifically contract cleaners, maybe contract caterers, agency nurses, agency health and healthcare assistants and home
all
carers.
Individuals who are healthcare workers who are identified as at the front line, all individuals.
And that would include contract cleaners?
And it'll include people in the community like primary care staff, GPs or anyone who's
They're very easily identifiable as healthcare workers. I'm talking about people who would be on contract working in hospitals for private entities. They're included in those figures as well? So
all healthcare workers, yes, at the front line.
Okay, so that is not my understanding, but I'm happy to receive that.
In relation to nursing homes, again, I'm conscious of time. I could say a lot in relation to nursing homes. Yes, the approach has been both reactive and proactive. I mean, reactive is a necessary part of the response. It's the whole purpose of an epidemic response. We have to react and unfold to an unfolding situation. What we see today and what we decide to do today might, by virtue of what we know tomorrow, turn out to be something we need to supplement or change. That's the nature of a public health reaction. Just to point out that the first confirmed case in this country was on the 29th of February, as you're aware. At that point, the advice, and it came a couple of days later from the ECDC, said that there was no strong evidence of transmission of infection preceding symptom onset. That was the advice at that point after we'd had our first case, and we know that that's no longer true. And so that's the advice that we were acting on at that point in time. And I can go through.
Last question. All of the advice that I have read anyway indicates that 72 hours should be the time for testing and contact tracing. How close to that are we? And would you be confident with the capacity to swab that the capacity is there to also contact trace and follow up, specifically in the context of workers returning to work this week? And I'm conscious of the time.
Yeah, I think we can be confident of that. I think a huge amount of work has been done in the HSE, and I know they'll be able to add a lot more detail. I'm conscious of the time. The turnaround times have improved very significantly, and the improvement in those hasn't finished. And some of the innovations that have been introduced in that contact tracing regime and testing and sampling regime in this country, I think, are without precedent internationally. So now people who are subject to testing get negative test results by text. With our positivity rate at the moment at 3%, they're getting a result. 97% of people are getting a result in that way. And there was a challenge in getting negative results back to individuals, and that's been removed. There are other arrangements in terms of a phone line arrangement for GPs where there is a challenge in getting a result to a patient where they can make same-day contact in relation to that. And the
but it's still not 72 hours, though.
Of contact tracing is happening within 24 hours. So, yeah. You're welcome.
I'd now like to call upon Deputy O'Dowd for 5 minutes, I understand.
It's 2.5 minutes in speaking, and I have one question, and I'll ask the witnesses to respond as they wish at that point. I want to first of all congratulate them on their excellent professionalism, their work, their credibility that they have, and also all the health workers who have given so much to all of us, and all the essential workers in the country, how much we respect them for what they have done. And I want to ask a question about all of those people who sadly have passed in our nursing homes. And I know it's not just in Ireland that's happening, it's happening all over the world. And if we want to benchmark the state of our nursing homes, public and private, and this is the nature of my question, the last published data is August 2019, 31,000 residents, 581 homes. Only 128 of those homes were fully compliant with the HICWA regulations. That's 123 out of 581. that percentage of compliance was down from 27% in 2017 to 23% in 2018. Regulation 27, which deals specifically with infection control, was inspected by HICWA in only 215 of those homes. 215 out of 581 were inspected in 2018. And of those, 37 were non-compliant. So there was an 18% non-compliance in the very basic protection for all of those residents in terms of infection control. And there are other issues in my question. This report, which is a HICWA report, governance and management, 32% non-compliance. Fire precautions, 34% non-compliance. Residents' rights, 27% compliance. Risk management, 22% non-compliance. Training and staff development, 19% non-compliance. So were you aware, or did HICWA advise you about what was the benchmark you were given for the fight you had to fight, given that your hands were clearly tied by the fact that this was a new virus the world had never seen before? But as you acknowledge, we knew that nursing homes were most vulnerable. We knew from the evidence that this was going to be the case. So my question is very clear. Can you give an absolute categorical assurance to me now that all homes, public and private, in this state are fully compliant in infection control?
Thank you. Who do you wish to answer that question, Deputy Dowd? Who do you wish to answer the question? Both?
I'm happy to kick off. Yep. Can I just thank you for the congratulations, but particularly to say that what we've been engaged in is providing advice on an overall framework. All of the progress that has been made by the Irish people. So there's no one actor in this. There's been cross-party support for it. Every sector has given support to it. But ultimately it's the behaviour change that we have made and that we will have to sustain into the future. In relation to nursing homes, undoubtedly anybody who has observed, as I have, nursing homes over an extended period has seen the development of that sector and the regulation of that sector, as you refer to in relation to HICWA, the introduction of new standards and new guidance, infection control guidance being particularly relevant in this situation. And we have infection control standards in place. The current version of it, I think, is from 2018. That would be very consciously part of the responsibilities of the people in charge of those nursing homes, whether they're private or public. And HICWA plays a very important role in reinforcing that responsibility. They have done so throughout the Covid-19 crisis. They're currently engaged in an assessment process in relation to Covid-19. But right from the start, HICWA reached out and issued out guidance and notices to providers about their responsibilities. That's not to say that this is easy. The CMO can talk to it, but this is a much more infectious virus than, for example, the typical flu we experience, and it's much more severe in its impact. And yet it's hard to keep flu out of a nursing home during the winter period. So a lot of work has gone into the sector. I won't say all of it has been perfectly executed. I won't say that there hasn't been learning in it. There's been a great deal of learning. And Tony has talked about the fact that the WHO and ECDC have updated their guidance in relation to this. But there is no doubt that this is an absolute focus and continues to be an absolute focus of the overall public health effort, and the importance of ensuring that everybody who's running a nursing home is very clear on what their responsibilities are, is very clear on what good practice is, and has the support to do that in every instance. That will be to the fore of how we continue to manage the virus.
Thank you very much, Mr. Breslin. I'd now like to call upon Deputy Smith of the Green Party for 5 minutes.
Thank you. I'm going to start with Mr. Breslin. I want to ask about people who have cancer, people with chronic illness, people who are in pain, who up to now have been attending private hospitals for non-elective, very necessary procedures, and their procedures were simply eliminated, or their appointments disappeared, and understandably there was this we needed the hospitals for the surge, or it was thought we would need them. And what is going to happen to those people, when are they going to get their when are they going to get treatment? Are any of them getting treatment at the moment, or is there an alternative path for them? Because people have been coming to me and saying, I've no idea when this is going to happen. Is there a date when we're going to return to treating at least non-elective people who require this? And I presume that some of these people will die, and that this will be seen in the mortality stats at the end of the year. That's the first thing. Second thing is that our hospital system, as you know, is often at 100% capacity. So not just our emergency departments, but also our acute hospitals. And in the future, we will have reduced capacity. So because of social distancing, we'll be down to 60 or 70%. And how are we going to cope in that situation? It would seem that we do need the excess from the private hospitals, but we need to obtain it in a different way. And I think Deputy Donnelly was referring to this. You know, is there a way that we can use a less crude method than just sequestering an entire empty private hospital? Can we obtain the procedures that we need to meet that extra capacity that will be required?
Thank you, Deputy. In terms of the activity that's currently underway in private hospitals, I might just place on the record that 6,646 inpatient discharges have taken place, 21,350 day cases. Often that would be chemotherapy, could be within that. 26,386 diagnostic procedures and 15,862 outpatient procedures. I expect all of those figures to increase as we are going through this period.
So what period are those?
That's up to last week.
The last week, yeah.
So one of the factors is that the whole health service was restricted in what it was doing because of the presence of the virus to the extent it was within our community, and that did affect private hospitals. What I would also say is that we concluded the heads of terms with the private hospitals, but there were protracted discussions with private hospital consultants. We have over 280 private hospital consultants on board. More are finalising their position with us. That's the majority of the cohort. The private hospitals are happy with the sign-up that they have at this stage, and that it can work their hospitals, and we have the manpower to do so. What I would say in relation to the continuity of care issues that you talked about, that is dependent on the consultant under whose care somebody's been treated. If that consultant signs up to the arrangements, all of their patients move across with them at the very point in treatment that they are. They don't go back to the start of the queue. They don't go on to back to a GP. They stay with that consultant based on the point on the care spectrum they are. The one distinction is, the one difference is, they don't pay a fee, or nor does the health insurer pay a fee to that hospital consultant. And the reason is, we are going to give a salary to the hospital consultant, so they can't be paid twice.
And how many consultants have signed up to this deal at this stage?
Over 280 consultants have signed up. In the event that they don't sign up, then arrangements are in place with the patient for the patient to decide, do they want to stay with that private hospital consultant? And they might stay with them in their outpatient rooms if that's the type of care they're receiving. Or do they want to move across? And if they move across either to another private hospital consultant that has signed up, or to a consultant assigned from within the public system. And to go to the point about how much activity can be done in this period, we are organising and reorganising all of the activity. So there's lots of things that were happening in public hospitals that have now moved lock, stock and barrel into a private hospital. Keep it away from an area that might have COVID, run it in the private hospital and run it in a facility that's purpose-built for that. So the private hospital facility is an important contribution to how we meet healthcare needs at this stage, and what we will have to review is the extent to which we continue with that. But the point I do make, and I made it earlier, was the mandate we started from was not to have a dual system of public funds going into a private hospital and then fee income coming in at the same time. We may change that, but the question that presents in that situation is, are there different incentives for treating private patients in that situation?
How many consultants are not signed up?
It's about 450. There's some consultants that have very, sessional commitments. They would be retired, but we think about 450 in total. And there's a good chunk that are in the process of signing up on top of the 280.
Thank you, Mr. President. I'd now like to Deputy Duncan Smith of the Labour Party has 5 minutes.
Thank you. I'd like to direct most of my questions to the CMO, please, and I'd like if we could just go back and forth on questions. The answers shouldn't take too long. And just to thank yourself and the Secretary General for all the work and leadership you have been showing over the last number of months. To the CMO, could I just ask, what was the thought process, what was your thinking in terms of announcing the capacity for 100,000 tests per week back in the 17th of April, given that we are now a month onwards, and if, according to the Jen's statement, says we are on the cusp of meeting that target now. The statement from the CEO, who's coming at the next session, says we are at that target today. So I'm still uncertain as to whether we have that capacity now. I know either way we're close, but what was your process behind stating that without first consultation with the HSE?
Is the microphone? Mr. Holland's, Dr. Holland's microphone on? Yes, it is now.
Yeah, we're at that capacity now, Deputy, and we think that's the scale that we need for the various different categories. I can explain what that is composed of. That number was arrived at as a result of the work we did at the National Public Health Emergency Team, which is attended not only by people from the department and a range of other organisations, but the senior leadership of the HSE, who are all party to that discussion. So our collective assessment was that's what we believe we needed. That's the target that we set out to achieve, and that has now been achieved. But it's not the only target that's important. The key target from our point of view is actually the turnaround. What length of time can it take to get a piece of information back to a patient, or in respect of a patient to a public health team, to allow the necessary processes of contact tracing or clinical management if it's a patient who is unwell and where clinical management is needed for that individual patient. That's the critical thing.
No, I appreciate that. Thank you.
So the total volume, and in fact we might find as we go on, as this pandemic unfolds and there's new, and I should make the committee aware of this, you may or may not be aware, literally this morning the ECDC has published new surveillance of Covid-19 at long-term residential care facilities in the EU. It's hot off the presses this morning, this morning's date on it. It is recommending testing in respect of staff of long-term residential facilities at the rate of something like
I'm not disputing the amount that's needed.
I'm just saying that there is, I'm not suggesting you, but there is generally a fixation on a number of 100,000. In fact, it might need to be fluid. We might find we need more testing. We might find, and we know we're not using that volume of testing right at the moment, because we have more than sufficient in terms of our capacity right now.
I think
but the needs will change.
The fixation on that was probably set by the statement on the April 17th. But look, I'm happy that we're at that capacity. How many members?
It's been the target.
Sorry, CMO, with all due respect, I have 2 minutes left. How many members were on NEFIT in meeting 1, and how many now how many members is there in NEFIT in meeting 31, which I believe is the most recent meeting? How are the recommendations from NEFIT communicated to the National Crisis Management Team and the HSE? Is it in a report? Is it in the minutes of the NEFIT meetings? If so, can they be published? I think we're 7 meetings behind now, maybe more, in terms of not being published. How are members of NEFIT appointed? Is there a specific protocol that the Minister has to sign off on? Who is the key decision maker in terms of appointing people to NEFIT? And yeah, and I'll leave it at that, please.
So, I mean, there's a series of questions there. I haven't, and to be honest, internalised every single one of them, and haven't come prepared with the specific pieces of information, so I can't tell you exactly how many people were there, but I'm going to tell you that it was probably in the order of 10 or a dozen. NEFIT has grown over the time period according to our needs. And that's the nature of that particular. We've used it on many occasions in the past as a structure to guide our response. Its composition, its size, its scale, its expertise depends on what our needs are at a point in time. So we brought on or co-opted people at various points along the way. The minutes, as you're asking about, I think you're not up to date. There is even over the last number of days, we've caught up in terms of minutes. But it's important to understand the process that we use. So, and you're asking about the question for how we capture decisions and conclusions. What we do within each meeting, before the conclusion of the meeting, agree on the conclusions and the actions that form the basis of the advice that goes either to the Minister and through the Minister to Government, or to the HSE, to the CEO. And we agree that in the meeting. The text, the final part of the meeting is the agreement of that. That then frames the body of the letter. So we don't wait until a set of minutes are to be finalised before acting, because we need to be in a position to act quickly, and that's the whole nature of the exercise.
That's encouraging.
The catching up then on the administrative task of publishing the minutes, yes, that's lagged a little behind, and we're trying to catch up on that. But the volume of activity we've had, I would suggest, if 31, 32 meetings with an average duration of 3 to 4 hours. In some of the weeks we've had 3 and 4 meetings of that, meeting late into the night and the early hours of the morning. The challenge of keeping up to date with all the administrative tasks associated with that is significant, but it has not delayed our decision making. It has not delayed our advice to government.
If we could see that correspondence as a committee, that would be much appreciated.
Deputy Shortall.
Thanks, Chair. I'd like to welcome you both and thank you for your ongoing work. I have 3 questions for Dr. Holohan, and they concern decision making and the basis of decision making, the rationale, and the need to, I think, be much more transparent about that decision making, not least to keep the public and everybody else with you. And we are quite different to other countries in terms of not releasing a lot of the data, making it kind of, open source and explaining as we go along. And for example, in Denmark, when the decision was taken to open schools there was a full risk assessment done. And the outcome of that was published. So everybody knew that, the R0 was likely to go up a small bit, and it did go up a small bit, but came back down. So everybody was bought into the decision to reopen the schools. So I'm not specifically talking about schools, but I'm talking about the need for very robust risk assessment and to be very open and transparent about that. So can you tell us just in general, in relation to all of the decisions and major decisions that you're making, what is the expertise and what kind of tools have you available to you to risk assess all of those big decisions? That's the first question. The second question relates then to the R0 number, which is currently around 0.5. That's very hard to understand given the kind of profile of people who have been tested in recent times. They would have been in the main people who would have had a lot of contacts and presumably a lot of transmission. So is that R0 number based on a theoretical model or what is it based on? And can you publish the model? My third question then relates to the behaviour of the virus in the community, and you've talked about this, Dr. Holohan, a lot, and the need to understand the behaviour of the virus. So what is your current estimate of the prevalence of the virus in the community? It's very hard to understand that, and looking at, say, recent figures, last night the figure of new cases was 88, and that's fantastic that it's down so low. But if you take that 88 as being 3% positive rate, then the total number of people tested, whose results we got yesterday, is less than 3,000. And again, that just doesn't sit logically with the approach of needing 15,000 tests done a day. So how can you explain what looks like a disconnect there? Thank you.
Okay, if I take them perhaps in the order, the reverse order, if that's okay. Yes, we're not testing at the scale of 15,000 a day at the moment. We know we're not. One of the things we wanted to bring forward, and we would have been discussing this morning in the National Public Health Emergency Team, but that meeting is not taking place now this morning, is the question of what will be next, if you like, in terms of our priorities around testing and where we would direct that capacity. In broad terms, the 3% positivity rate reflects what we think is happening in the community. But there are other categories of testing I think we're going to have to prioritise into the future. We think in the healthcare environment, for example, in hospital settings, but it won't just be hospital settings, as we increase the amount, hopefully, of non-COVID care that we provide, testing both patients and staff will become a feature.
But it is based on less than 3,000 tested.
In broad terms, that's correct, yes.
Yeah,
and there is something of a weekend effect in that.
Yeah.
One of the things, just if I can just add to that will help in terms of our understanding of the community, and I think you're right, I accept the point that you're making, will be the decision that we've taken to introduce this week now with the easing of restrictions, which many other countries are not doing, is the testing of contacts of close cases.
Yeah. Okay.
And that will add significantly to our understanding of community transmission, asymptomatic transmission, and give us a much greater response, if you like, in terms of our handling on that. In terms of the R0, it's based on the summation of 3 models.
Will you publish that model?
And it is due to be published. It is and I would have to check with the chair, but my understanding is that the work, if you like, to publish it is going through a peer review process at the moment. I can't honestly tell you right now what the timeline is in relation to that. But yes, the intention is to publish that.
I think it's important.
Yes, absolutely. I agree. I agree entirely.
It hasn't been done.
And in relation to the expertises, we have a range of different expertises at the NEFIT in relation to our public health assessments. And a range of different epidemiological and mathematical modelling expertises, public health, geriatrics, psychiatry, and then a
so
range
again,
of other
would
supporting
you commit
specialists.
to publishing those risk assessments for the big decisions taken, say in relation to the construction industry or schools or whatever? I mean, it's important just that we're aware of the basis.
What I wanted to point out was that in relation to those assessments, so let's say an assessment in relation to a school setting, so some of that work and in some of those circumstances will be done by the relevant sector. So we give public health advice, we support other sectors in the decisions that they have to make around the actions that they need to take, internalising our public health advice into the way, for example, in which they organise and monitor.
Would you favour publication? Would you favour publication of those risk assessments?
Any of the material that we have available to us, that is our public health consideration. We frame it in the minutes and we publish it, and I have no difficulty in making that.
Thanks.
Just one last question. You said that the assessment was being peer reviewed, and you couldn't tell us now what the timeline was. Once you go back, can you let us know by correspondence what the timeline is?
I just have to check with Philip Nolan, who's the chair of the group. Yes, so he's leading that particular work. I just don't know that piece of information at this point. But I know that the intention is to publish it by way of peer review, or to publish that model. Yeah.
And you can let us know roughly what the timeline is anticipated to be.
Yeah, I'll find that out and absolutely let you know. Yeah.
The Solidarity People Before Profit, Deputy Richard Barrett, 5 minutes.
Tony, and for all the work that you've done, I don't think anybody doubts that. You said you had concern about health workers, and we know that the infection rate among health care workers is very high. I think 31%, Tony, you said. Why is it so much higher among Irish healthcare workers than it is, for example, I think in other jurisdictions, is one of the highest? Why is that the case? And I want to know what advice you got in relation to healthcare workers, because I've been asking about this since the second week of March. According to the NEFIT minutes, you got 2 advices from the Expert Advisory Group, I think on the 7th of March and on the 10th of March in relation to healthcare workers. On the 16th of March, I asked what those advices were. I still haven't had an answer, and I've asked repeatedly to see the advices and recommendations and the minutes from the Expert Advisory Group. Now, this is terribly important given the high level of infection among our healthcare workers. And just to bring you up to speed where this is at, and I just do not understand this, an agency nurse who was recruited to a Dublin hospital 2 weeks ago has tested positive for the coronavirus in the last few days. She was never tested entering into that hospital where there's a lot of elderly people. Now, I just do not understand this. So I'd like to see the advices that were given way back in March by the Expert Advisory Group in relation to healthcare workers, and I'd like an explanation as to why we have such a high infection rate among healthcare workers, and how on earth can we have a situation where healthcare workers are coming in to work with vulnerable people 2 months into this crisis, when we know there's a problem with healthcare workers' infection rate, and they're not being tested before they start work with elderly people, and then we discover 2 weeks later. And for example, healthcare workers are going to visit the elderly in their homes at the moment. Are they being tested before they do that work? Are there regular tests of healthcare workers when they're working to make sure that they're not infected? So I would appreciate answers to those questions, and could we please see the advices and minutes of the Expert Advisory Group, which I've been asking for 2 months?
Thank you.
The latter question, yes, and I'll engage with the chair of that group in relation to that question as to when that can happen. The minutes and the advices of the Expert Advisory Group. We have, for the most part, acted on all the advice that the Expert Advisory Group has given to the NEFIT over the course of this, and I see no difficulty in making that clear and making that available to you. Just to point out, and I've already made reference to this, there is new guidance from the ECDC literally this morning in relation to the whole question of testing, and we'll be looking at that and what that means for us, as other countries will be in relation to testing. I can't answer the specifics of an individual nurse, as you'll appreciate, as to why an individual isn't tested. We've had a very significant programme of testing throughout the residential and community residential sector, including nursing homes, that has tested staff in all settings and patients in settings guided by the disease. And it's been a public health-led set of decisions that have determined who gets tested and when. And the team in the HSE at the HPSE that's doing that work is continuing to assess how we should, in public health terms, direct the appropriate prioritisation of testing. And as I said, at our next meeting of NEFIT, which was due to be this morning, we would be considering that question of prioritisation, the next categories that we think are important in terms of testing, and in particular what needs to be the ongoing programme of testing for people who either work or who reside in long-term residential care facilities, and people in exactly the categories that you're asking about.
Very quick question on another matter. We're signed up to the European project on blood plasma, convalescent blood plasma therapy. I've asked also a number of weeks ago for a report on how that's going. The results are promising, and I understand that there are pheresis machines for the extraction of blood plasma up in James's Hospital, that there are 500 people who've offered to make donations who have recovered from COVID-19, but those machines are not being used to extract that blood plasma. So I'd like to know what's happening there.
And I wasn't aware that you were going to ask that specific question, so I don't have that specific answer, but we'll get it for you for sure, Deputy. We'll correspond to you directly on it.
Thank you, Deputy Boyd-Barrett. On behalf of the regional group, Deputy Shanahan, you have 5 minutes.
Thank you, Chair. Thank you, gentlemen, for your attendance here today. Just some questions for Mr. Breslin, and then I'd ask the CMO if you could just leave time for the CMO just for the last couple, if you please. In relation to tracing and testing, just wondering who is responsible for managing the positive tests and who for the negative tests. So in relation to some information brought in by Deputy Naughton during the week with respect to meat factories, we've had contacts going out to management in meat factories, not going direct to the patients, to say that patients were tested positive. And on the other hand, we've had negative test results which have been more than a couple of weeks coming back. So there's significant issues there which you might address, please. The other thing, in relation to the private hospital situation, 45% of our population have private health insurance and at the moment are being excluded from accessing their general consultants' work and any opportunity to have treatment. Could I ask you just in terms of, you said that a significant number of doctors have signed up to the Type A contract. I'd ask you how many surgeons have signed up to the Type A contract. Would be my understanding in the private hospitals where a lot of elective work is done. If you don't have a surgeon to do it, it's not much point having the other consultant staff on board. Just beyond that too, with respect to the hospital contract, we have 115 million going out per month for securing that. I see from data of the 18th of May, only 30% of the beds in the private hospitals were taken up. I would say these are not patients. Many are long-stay patients from the public hospitals which have been moved out. So I think the NTPF annual budget is about 30 to 50 million euro per year, and we're spending 115 million. I would like to see that contract revised, certainly. Just in relation then to UHW, can I put something on the record which is not quite COVID related but is as a fact of it? We had a diagnostic cardiac diagnostic lab facility on site there since September 2017, which was moved off the premises in the last couple of weeks. The contract was not extended. We're now back to one cardiac cath lab in the southeast for the 500,000 people. We have a hospital with 160 beds. Sorry, Chair. No, it is related to COVID, Chair.
COVID response.
Yes, I understand. I just make the point, if I may, Chair. We have 160 beds in the hospital. We have only 3 patients in there presently for COVID. So I would just ask you to reflect on that. And just in terms of the CMO, can I ask you, CMO, in relation to ongoing treatment, is there any update on hydroxychloroquine, the idea of using vitamins, particularly vitamin D, to supplement the elderly, and zinc? And also your thoughts on antibody testing. Can this be used at any point in the future? And the other one point I'd make with respect to Waterford having the lowest incidence of COVID in the country, why can the regions not be allowed to open in advance of the major population centres? Thank you.
Thanks. I just remind witnesses that are only asked to answer questions in relation to COVID response.
which is the positive test. Tony can confirm this. The procedure is contact tracing would take place with the individual. So I'm not aware or can't understand what the issue that has arisen with an employer getting a result in the absence of
it's been communicated to your department.
But I can talk to you about the policy, which is that it would go back to that individual who has been the subject to the test. There have, as Tony has referred to, there have been delays with negative tests. Probably a negative test is the one that's less concerning to the contact tracer, but as Tony has outlined, we've now automated that, so that will flow very readily. 97% will go back with a text message. In relation to the private hospitals, I wouldn't agree that 45% of people have been excluded. The private hospitals are open to the whole community at this stage. It's a clinical judgment as to who gets admitted, and that won't be decided based on somebody's insurance, but that equally means if somebody is insured and they're clinically necessary to be admitted, then they're eligible for admission. In relation to the number of surgeons, I don't have the exact number, but I wouldn't expect that there is the type of huge bias that you're inferring. Surgeons need hospitals. And so they would want to, in order to practice, they would want to have access to private hospitals. There are some other specialties that don't need hospitals as much. They can do a lot of their work in an outpatient setting, and they may be less represented in the numbers that have signed up. But we haven't experienced a major problem in terms of surgeons different to other doctors. We've had some delay in everybody signing up, but not specific to surgeons. I might leave Tony to comment on the others. I wasn't going to comment on the cath lab, but I do know the full extent of the concern and the issues and all of the work that has gone in both by the HSE and nationally on it. So
just
it's
leave time for Dr. Holden.
Just to be clear, yes, I mean, we have had some reports. The microphone, I think, is on, not on again.
Yes, it's on.
Some reports of employers receiving results in respect of individual patients. That's a breach of confidentiality.
Okay,
Full
thank
stop.
you. We're out of time, Deputy Shannon, but
okay.
Maybe if you wish to answer any other questions, so my correspondence. I'm sorry, I have to be fairly ruthless with time to make sure that everybody gets a fair crack at the whip. The Rural Independent Group, Deputy Collins.
Both gentlemen for being here before us today, hugely important. I suppose our questions that the public have out there and we need to have answers from. I suppose in relation to testing, initially, Mr. President, maybe you might be able to answer me that. I know that you know, we've sent a lot of the samples out to Germany at a massive cost. And I looked there today, I think they've acquired a new plane to fly them in and out of the country. I've been talking to, you know, labs here and testing that could have been done in Ireland. One such Animal Health Lab Limited, who are testing for COVID-19. Tests going in the morning, results in the evening. They felt that they had a little bit more resources. They could have done anything up to 5,000 plus a week. And while they're being considered by private hospitals, they haven't been considered totally by the HSE. Why did we go to the massive expense of flying our samples out basically to Germany, waiting maybe sometimes up to three weeks? I've had cancer patients come back to me, can't have cancer treatment because they're waiting 3 weeks for results, and still we find out that this could have been done in Ireland, and obviously creating jobs here locally, and maybe something that needs to be looked going forward. You know, I'm not trying to point fingers here, because you've done some tremendous work, and I don't want to be seen to be critical in any way, but I think that's the point. I'd really appreciate an answer. The HSE, we'll say, take over state of the 19 private hospitals, which is costing 115 million euros per month. And while it's completely understandable that a deal had to be done initially to secure capacity for COVID-19, obviously no one ever knew where this would go initially, and you had to. The light switch for medical care for all other patients has been turned off, and there are at present 2.2 million Irish citizens with private health care who will have no option but to join the public waiting list as of April the 30th. The TPF had 770,000 people in hospital clinics. Now, in other countries, they've had to do something similar, and they've reverted back, and I'm asking the same thing. Are you considering that basically going maybe gradually reopening these private hospitals to people that have private health insurance. I think it's very important, and there's a fierce worry out there that people with serious issues and health issues need to be seen after, and they're paying private insurance, and that isn't happening at the present time. I suppose another question: did the HSE and their consultations remove elderly and sick people from our hospitals and put them into nursing homes, community hospitals, without testing them? That's a question I'd like to ask. And there's other questions, but I'd like to get answers here now, so maybe I'll leave you to the answers there.
On the German lab, I can't say it's not more expensive than Irish labs, including some of the labs that we've introduced more recently. The number of labs that are now testing has gone from 1 in the National Virus Reference Laboratory to 41. So we have taken account of capacity where we've been able to find it. The reference to lengths of time, there was a backlog of tests that went to Germany, and therefore by the time those people got the result, there was a delay. But actually, the results coming back from Germany are very much within the next day, and there's not that length of time. Obviously, the HSE will always look commercially at where it's best to do this and have regard to the turnaround time. So that will be a dynamic situation. We'll obviously keep that under review as we go along. We have added in significant private sector labs in Ireland. One of our biggest labs now is a private sector lab. So there's an openness in the HSE to trying to secure turnaround and cost effectiveness, but also the quality that we need, and that will be foremost. In relation to the private hospitals, I've kind of said what I've said in relation to it. I don't envisage that people have to go right back to the start of a waiting list. That's not what the policy says. There will be a review before the end of the month. We will take into account everything, but one of the things we'll have to take into account is the World Health Organization's advice that the most likely scenario here is for recurring waves. So the idea that we had our experience and now we can move on is absolutely not the case. We could be subject to a further wave, in which case we would be back looking at a modest amount of ICU capacity within our public health service and wondering will we be able to cope in that situation. So there are strong arguments for using all of the capacity that we have nationally and for reviewing it on that basis.
Thanks very much, Mr. President. Just a quick question. All labs and all testing is contracted directly with the HSE rather than with the department, is that correct?
Yes.
Thank you. Deputy Collins, you have 15 seconds.
Yeah, I appreciate the answers there. And I suppose one other question in relation to, I suppose, a lot of home helps, they were very late in the day getting their PPE equipment, and it was a serious worry to them. And,
Deputy Collins, I just asked maybe speak.
We have very good relationships with the home help sector, and they've played a very important role. There is a relationship with the local community health office in terms of PPE, but also they've been very flexible. They've gone in and worked in nursing homes in the most critical phase.
Thank you, Mr. President.
One of the things going forward will be to try and get that service back up and running. It's really important that we have a home help service into the future to try and cope.
Thank you. Thank you. The next Fianna Fáil speaker is Mr. John McGuinness for 5 minutes.
In relation to the carers in the home, have you examined their role in all of this and how they are being supported? In terms of the Section 39s, mentally and physically challenged clients of those services were caught for cash and funding before this happened. So has funding been released to those organisations to ensure that they can expand the role that they have and indeed support what is now required because of COVID-19? In terms of reopening the economy, have you looked at France and their red and blue counties and numbers, urban and rural, in terms of a response to either one, separate responses? It seems to be a plan worth looking at. The private hospital deal, €115 million a month, has been mentioned. Is it €115 million a month, and has it gone over €115 million a month? And if so, can you tell us why? Are the consultants involved in the hospitals, are they being compensated for the loss of their business plan in terms of the rooms they rent or lease or have purchased, the staff that they employ? Where are all of those? Where have all of those staff gone? Are they being compensated, is the question. And is there an overall plan for the use of private hospitals in terms of a solid plan that people can refer to? Because up to last week I think there was not a plan. The loss of 3 months of normal service so far in these private hospitals is projected to cause 1,800 extra deaths from cancer. Are these figures that you are familiar with? This would be 20 people a day that would die from cancer. And I'd like to have clarification around all of the services offered to them. How many of the private hospitals and how many patients had their appointments cancelled over the last week? And in terms of the deal itself on the 115 million, would it not have been a better idea to have a contingency there for a capacity that will be made available should it be needed? I know that in some hospitals, for the beginning of this particular takeover of or deal with the Private Hospital Association, there was a handful of patients. Scopes have been cancelled in public hospitals, and those scopes have now, there's a backlog of 4,000 plus. What are you doing about that?
Deputy McGuinness, just time to answer the questions as well.
In terms of the private hospitals, what I would say, we do have to go back in time here. What we had seen in Italy, what we had seen in France, what we were beginning to experience ourselves as we moved towards the end of March, we were rapidly, if you looked at the trajectory of admissions into our ICUs and our public hospitals, they were going to rapidly fill up. Within a week, we would have exceeded our ICU capacity. So that was a focus of the arrangement that we put in place, that we needed immediate access to those facilities. In terms of where we go forward, we will obviously review it. But as I said earlier, we will have to review it in a situation where we could find ourselves back in that situation quite readily. The other thing to stress is, during that period, non-COVID care fell off across all healthcare services and across all sectors, both the public hospital sector and the private hospital sector. You saw it in terms of emergency department attendance.
Sorry, I interrupt. I'm just watching my time here. I've asked specifically about the contract and about the consultants and their business plan.
Happy to.
So what is the position there?
The consultants receive a Type A contract and are remunerated for that. In some instances where there is a business case where their outpatient rooms would need to be used for the delivery of public care paid for by the public purse, a HSE has been given the authority to enter into arrangements as long as they're value for money. That doesn't underwrite all the business losses that somebody had. There's whole sectors of the economy that are experiencing that, and there are arrangements in place separate from the health service for that.
Well, can you deal with the other questions I asked then in relation to
which one? 30 seconds.
The cancellation of the private appointments and so on, about the funding for Section 9s.
So the HSE in the afternoon will outline the very close working relationship they have with Section 39s, and there have been arrangements put in place on a case-by-case basis where they've been affected by COVID. They may be taking on extra duties, or they may have incurred extra costs, and the HSE is a process for that. The government has put in place a scheme for charities in general as well.
Could I ask, Chairman, that maybe some of the questions that weren't answered, which are particularly relevant to consultants and their operation of their business, that they be answered in writing?
Mr. President,
I think I covered all of the consultant questions, but there are one or two of the others.
You're very flippant, actually, about the consultants and their business plans and how they were going to be written off.
Thank you, Deputy McGuinness. Mr. President, are you happy to answer the questions? We can recap them if necessary after the meeting.
Surely.
Thank you very much. We can go back over the manuscript, or the Dáil debate to see what was asked. Thank you. Deputy Cullen, we are very much over time. I appreciate you taking Deputy Carthy's time, but I'd ask you to limit it to 7 minutes.
Sequence, does that not mean there's a Fine Gael speaker due to ask now?
No, it's Sinn Féin is the next speaker, and then it's Fine Gael, because Sinn Féin has somebody give up time for one like Fine Gael. But I would ask you to limit it to 7 minutes, because otherwise people here aren't going to get to speak at all.
Okay, we won't quarrel in public. We can deal with that later. No, we'll just proceed. Thanks for that, Chair. And I want to welcome the two witnesses and to thank them for their work, but also the teams of people that are behind you. So I just want to send our best wishes, or my best wishes, to all of your team, and to commend you for the work that you've done. I'll put my questions very distinctly, and I know the witnesses are very experienced and they'll equally respond in a distinct way as well. And also to say it's the first opportunity we have to look back. I think it is important for us to look forward, and I'll do that in relation to testing and tracing. But in relation to nursing homes and congregated settings, I think there are questions that just need to be put on the record, and I want to put the questions to Mr Houlihan first. My understanding, Mr Houlihan, is that Nursing Homes Ireland, when they first responded to the COVID-19 crisis, that on the 4th of March that they imposed nationwide visiting restrictions on private facilities. Is that correct?
Confirmed that it was the 4th. It was in the early days of March.
It was the early days of March.
I have no reason to dispute the 4th of March.
It was the 4th of March. And then on the 10th of March, I think on your advice, the blanket restrictions were lifted. That was advice that was given to nursing homes. Is that correct?
No, it was not given to nursing homes. It was advice in public that was a broader piece of advice that related not only to nursing homes, but a range of different actions that were happening over the course of that week. So that was the advice we gave in public. We talked about it at the meeting of our National Public Health Emergency Team on that date in relation to nursing homes, because we had a substantial concern that there was a lot of unilateral action taking place over the course of that week. A lot of organisations taking their own decisions about what public health actions they needed to take, not informed by our advice. And our clear concern was to try and ensure that we had all of the country, all of the organisations operating in step with our advice. That ultimately was what happened when the advice we gave to government was implemented on the 12th of March.
Okay, but on the 10th of March, sorry, on the 10th of March, the advice that you said it was given that there shouldn't be restrictions, that they were too restrictive. Are you saying that was in broad terms?
No, that's not correct. And I have been quoted in those terms as having said, and if you check our press release in relation to that time, we said that visitor restrictions in respect of nursing homes are not appropriate at this moment in time, which is a totally different thing to what has been interpreted by many people as saying...
Was there advice given to nursing homes? Was there any communication between your office and Nursing Homes Ireland on any of that?
There would have been engagement between Nursing Homes Ireland and the Department and the Minister, to which I personally was not a party.
But
so
three days later, then, after the whether it was an instruction or advice or whatever way it was put, and there's disagreements on how that was maybe presented in the public domain. If you just let me finish, how that was presented in the public domain may not be your view of it, but I think it was 3 days later, on the 13th of March, the visiting ban was imposed or reimposed. Is that correct?
So what we did on the 12th of March was to make a series of different pieces of advice around school closures, around a range of measures across society, which included a recommendation that visitors to nursing homes and healthcare facilities, that would cease. It was a change in our assessment of the disease on the 11th of March that led us to that point. Up to that point, we didn't think we should introduce such arrangements, because we understand that these are restrictions on people visiting their loved ones in places where they live. I should point out to you that, nevertheless, in terms of cross-country comparisons, and we've done this, the length of time between a country reporting its first case and then implementing visitor restrictions in the way that we did on that occasion, we were the quickest country in the world.
But how many clusters do we now have in nursing homes? How many clusters have been identified in nursing homes and residential settings?
I can tell you the number.
It's in the hundreds anyway, isn't it?
It's over 200.
It's over 200. I think we can all accept that that's very, very high. And
it is, but it doesn't. It doesn't relate to visitor restrictions, because we know that the point at which visitor restrictions were recommended by us, which was on the 12th of March, we had no reported clusters at that moment in time. It was the earliest point in the world. No country made such a recommendation relative to their path of infection earlier than we did. So it's a range of countries, and I can go through them, and I don't want to waste your time, but I have that data here.
Well, you can forward us that, yeah. I just want to put a follow-up question to Mr. President.
Australia, Canada, a range of countries across Europe all took a substantially longer time to implement that, and we did that before the advice of the WHO and ECDC to introduce those recommendations.
Thank you, Mr. Houlihan.
And so we were very responsive to the disease.
Thank you, Mr. If I can put a question into Mr. Breslin, because I think there was correspondence between the NHI and your department around that time. So again, what we're hearing from the NHI is that they were seeking meetings with the Minister or officials. So if there was correspondence between the NHI and your office and the Minister, what was the nature of that correspondence? And can you share that correspondence with us? Because we'll have NHI in here next week. But first of all, if you can just respond to the nature, because my understanding is they were raising concerns in relation to the lack of an overall comprehensive plan for nursing homes. And we all know now, as has been repeated, the very high levels of incidence of COVID-19 in nursing homes. But what was the nature of that correspondence in that early stage in March that took place between your department and NHI?
So happy to share the correspondence. There's a great deal of tic-tacking with Nursing Homes Ireland as the representatives of the sector across a range of issues, and obviously in this period a range of issues connected with COVID. It related to specific issues, but it also related to their seeking engagement and representation on various structures. So at the time, Nursing Homes Ireland sought representation on subgroups in EFIT that had been set up. Some of those subgroups were actually doing the work of designing financial support schemes for the sector, so we didn't consider that that was the appropriate course. And also NEFIT is an expert group, and it has HICWA on it as the representative of the regulator of the sector.
Is it not also true, Mr. Breslin, that they had appealed for specific guidance on what to do in nursing homes and how nursing homes should respond to this crisis, and also that they predicted that nursing homes would experience severe staff shortages and concerns raised about PPE? Is that also correct?
But there's been a huge amount of guidance issued to.
But at that time, they were obviously not clear because they were looking for specific guidelines.
But as I referenced earlier, there's infection control guidance in the sector already there by HICWA. The HSPC issued guidance in early March setting out how to manage COVID-19, both to prevent it and if there was an infection in a nursing home. So there's been continually updated guidance to the sector, and as you will no doubt hear from the HSE in the afternoon, a huge range of supports put in place to try and help the sector. The sector is a mix of both publicly operated facilities and privately owned facilities. So it's not line managed in its entirety by the HSE. Much of it is outside the HSE.
And can I just ask that all correspondence related to NHI and the department and Mr. Houlihan's office and the HSE, if that could be forwarded to this committee in advance of next week's sittings, if that's possible. Thank you.
Mr. President, is it?
Yes.
Thank you. Deputy Brophy, you have 5 minutes.
Thank you very much, Chair. First of all, to endorse my colleagues' comments previously, to thank you and the Chief Medical Officer for your service. I want to address, though, the department specifically in my first question. Allowing for your opening statement and the preceding media coverage of it, that we are facing into a crisis which could be effectively years and not months. I want to just comment on one particular aspect in relation to the private hospitals and private insurance. Can I ask you, is it effectively an irrelevant thing for someone to do to have private health insurance now? Is there any logic, if you take your position as outlined, that you wish to retain private hospitals effectively under your control for the duration of the risk of the COVID-19 pandemic, which by your own statement is years? Effectively, there is no private healthcare in Ireland, and for most people that means an end effectively to private health insurance. There's no logic in paying private health insurance. Indeed, there's even a questionable logic in continuing to pay this year's private health insurance. You have said that someone who is in the system will obviously maintain their place in the system, but obviously am I correct in understanding that somebody entering with a new complaint, there is now no such thing? And is that a position which has government endorsement? Does it have departmental endorsement? And are we happy at a process whereby we completely say to people who paid tens of thousands of euros over their life in this country for private health insurance, that that money was in effect wasted?
So no, I think you've extrapolated. What I set in place was the policy that motivated the putting in place of the arrangement, and the arrangement is in place for 3 months. With the HSE has the option to extend that for a 4th month, and by agreement with the private hospitals, a 5th month. That's the arrangement that's in place. We are now coming up to the end of month 2, when we will do a review which will decide what we do after month 3. We will have to take...
Sorry, can I just come in? You twice in answer to colleagues' questions said that because of the risk of a surge capacity, you needed to maintain that capacity. If I take your answer through to its logical conclusion, if you need to maintain the surge capacity, if we have no vaccine and we have no treatment, and the point is the pandemic risk remains the same in terms of surge, well, that means we permanently have to maintain that capacity. Is that not correct?
So I wouldn't reduce it down to an either-or option. I think there will likely be different options that you could look as you now see where we are and what the future might hold. So it's not simply, do you do the deal that you did the last time? Do you continue with that? Or do you not do the deal? You could look at different options within that.
Appreciate time. Can you reassure people that you're not actually envisaging a situation which effectively amounts to the abolition of private health insurance?
No, and the health insurers have given a rebate on insurance for the period.
For a short period of time, but effectively, if we keep the hospital system the way it is, it's rebate. I want to conclude. If you don't,
just to say though, Deputy, it is by agreement. The state did not impose
I appreciate it's by agreement, but their subscribers have also got views on this, and there are people who are paying their hard-earned money into private health insurance for many, many years. I want to just go to a secondary area, and apologies for having to be so blunt, but I have a second question, which primarily is on to the Chief Medical Officer for advice in the area. When we were initially on this committee, we were told we could be broad-ranging in our questions to you today, so I know it's not in the core area. I want to specifically ask about the underpinning medical advice to the 14-day quarantine on entering the country, which has come into play. Obviously, as long as that remains in place, Ireland is in an effective lockdown zone as regards reopening for tourism and reopening for commercial the commercial life of the leisure industry, etc. Huge implications. To a lot of people, it seems a real, displaced point that you have Northern Ireland with an open border coming across and going back and forward, as we all want, but you have people landing in Dublin Airport with a 14-day lockdown, which effectively will literally kill our tourist industry. What is the medical advice that underpins the advice to government on that?
So it's public health advice. It relates to our assessment in relation to the potential incubation period of this virus. 14 days is pretty much an international consensus. Very few countries at variance with that particular measure. It's to try and ensure that we limit travel from overseas and have people coming in who don't spend, if you like, a period of time. The reason it doesn't exist for travel on the island is that our assessment is that, in broad terms, the island is behaving as one from a disease point of view. Northern Ireland, the incidence is broadly similar.
Accept that. While valid now, any idea of when that will be lifted or when we consider?
I couldn't give a commitment in relation to that. Just a general, which I know won't answer the question, no measure that we have recommended of this kind would be in place for any longer than we believe it's necessary. But it's simply too early to make an assessment, given even on the island of Great Britain and in many other European countries, let alone the US and the rest of the world, given the state of infection, how long we need to have that in place.
Thank you very much.
Deputy Burke, I'm conscious of the fact that both Sinn Féin and Fianna Fáil have had more speaking time than Fine Gael. I'm not going to be able to get to Deputy Foley, but Deputy Burke, I'd ask you to limit it to 2 minutes. I am sorry that Fine Gael has had less time in this session. It will be borne in mind.
I'm just going to touch on, there's a number of points I wanted to raise, but I'll just touch on one, and that's in relation to congregated settings within the HSE. I was in contact with someone who was in fact affected by COVID-19 and worked in a facility where a number of people died. They highlighted the fact that a simple thing like, for instance, there was no changing facilities within the facility for staff when they came into work in the morning. There were a number of people died. Then within a few days, all of the what the staff were looking for were put in place, but that was after a number of deaths. And I'm just wondering, at the very start of this process, was there an audit done to see, well, where are the congregated settings that are in danger? For instance, in this particular setting, there were 6 patients, psychiatric patients per ward. So therefore, once it got in there, it was high risk. I'm just wondering, was there a list made out of those areas? And we've had a number of HSE facilities where there was been more than 10 deaths. Was there a list made out? And it would appear to me from the evidence I've got that there was no action taken to deal with a crisis in those facilities.
I apologise for curtailing the speaking time. We're just going to have to learn from
Can we make up for it in the next session, Chair?
No, but yes, well, we'd certainly try to, but I don't want to take time. Deputy, or Mr. President.
So, Deputy, there was guidance issued to all of those sectors. As I said earlier, each of them are unique in their local infrastructure, and we recognise that in lots of situations we have multi-annual capital programmes in place to try and improve the infrastructure. So what one person will have to do in a particular centre will be different to another. HICWA as the regulator and the Mental Health Commission as the regulator have also risk-rated individual settings and kept in touch with HSE where they have concerns around that, and that process is continuing.
But Chair, nothing has been learned from this, because I was just speaking to the staff member in the last few days, and while certain new procedures were put in place, they have now disappeared again. In other words, for instance, each of the staff members were given a scrub suit so that they could put on when they came in. There's now none available when they come into work. So nothing has been learned from the process, and this is something that needs to be challenged at this stage.
From what the Deputy says, that is a centre that's regulated by HICWA or the Mental Health Commission, and I think both the HSE and HICWA or the Mental Health Commission will be very interested in those issues if they're of concern.
Thanks very much. Just to conclude, I've just two questions. Obviously, we've set out a roadmap of phases which may be brought forward or may take longer than we anticipate. But have we set out objective criteria for what will allow us to move from one phase to the next? And if so, in terms of transmission rate, in terms of ICU capacity, or any criteria? And if so, can those criteria be published? And where exactly are we? These are questions for Dr. Holan. Where exactly are we at with regard to transmission now in the country? Is sustained human transmission now limited to some parts of the country? Have we managed to limit it to some parts of the country?
In broad terms, we have effectively extinguished it from the community in general, right across the country, and much of the caseload that we see now being reported is reported in respect of particular settings. We are still seeing some positive numbers coming through residential care facilities, even though the numbers has reduced very substantially, and through some occupational settings. Not to say that there aren't some cases, but we have effectively extinguished it, which is the strategy from the very start. We have to start with suppressing this infection across the community to begin with, before we have a chance of protecting nursing homes or other specific settings. In respect of the specific question around criteria and measures, they may change from time to time, the actual threshold or the level at which we think it's important. So how we view, let's say, 30 people in an intensive care unit at a point in time would be very different if the day previously the number was 29 or if the day previously the number was 3. And so to set out the particular number depends very much on the context. So we have a series of criteria that are set out in the government's roadmap for recovery that set out the disease and a range of other characteristics in relation to testing, contact tracing, in relation to health service capacity, in relation to the broad impact of the measures on the health and well-being of the public. All of these are taken into account in the staged recommendations and advice to government around easing restrictions.
Thanks. Can I just take... sorry. I need to get us out here, and I just want to ask, can I take from what you said about transmission that we no longer have sustained human transmission in all areas of the country?
That's an absolute statement. I couldn't say that in absolute terms. We have it down to a very, very low level, effectively, I'm saying. But I can't say that there isn't. We don't have widespread sustained community transmission. We know that because we're not seeing the caseload, in spite of the fact that we have very substantial testing capacity in place. We're testing large numbers of people relative to the numbers of positive cases that are being identified. So we can be assured about that.
Thank you for your forbearance. Mr. President, did you want to...
I was just going to add that in addition to the advice that Tony has talked about on criteria, published on Friday was both public health advice, an economic assessment and a social assessment, and the government published all of those. So we pass the advice into government who make a decision, and they pull in multiple perspectives in making that.
No, I understand, but it's the medical criteria that will enable us to move forward or prevent us from moving forward that I was interested in. Thank you, and thank you all very much, especially to Deputy Foley. I do apologise, Deputy Foley, and it will be borne in mind for the next session. Thank you very much. And also to Fine Gael. We need to learn from maybe taking so much time in private session, but that's...
Some type of session at the start of the next, because it is unsatisfactory the way the timings went. I appreciate you were absolutely working, but it is unsatisfactory in terms of timings. One party enjoyed 17 minutes of questioning. That is not and cannot be allowed to happen. Yeah.
Yes, and you got 12. I do appreciate that. Thank you very much.